rest of you. I want to try to make this a little hodgepodge. We're kind of running out of time. It's almost noon. People have planes to catch. I just want to show you a couple of things I'm working on, and then we're going to throw it open to discussion. I'm going to ask you some questions. You can ask me some questions. We'll get the panel up here, and then we'll terminate this, and we'll all see you next year, if not sooner, okay?
Chris, you need the projector on?
In a minute. I just want to talk to you about some things that are really important from a political point of view. First of all, most of us in here are doing things that border on, according to the establishment, that might be out on a limb. You need to protect your assets. Have you all done a limited family partnership and that kind of stuff, or limited liability corporations? No? You better find an attorney in your neck of the woods that will protect you. You need to put all your assets. You as a practitioner should own nothing. You should just be David Kennedy DDS. That's it. You should own anything. A corporation owns your chair and your microscope and your house and your cars. You shouldn't own anything. Because it's going to come down to a point where sometime you're probably going to get sued for doing this kind of work. So you need to protect what you've earned all this time. So please consult with a trust attorney that's going to protect your assets. Limited liability corporations, limited family partnerships, revocable, irrevocable trust. That's what you need to do. If you own property or building, that goes into a separate trust. That's really, really difficult for the attorneys to get at in case you get sued. Does anybody not carry malpractice in here? You're smart. I think that's okay. When you've covered yourself with the other things, though. See, that's a possible way to do it. I always wonder if you get sued, you know how good your insurance company is going to be, your malpractice carrier. If they fold and all of a sudden you need them, or if you carried with somebody else before and you change companies and then a claim is made and they're since now out of business, how good are they now? So something to think about. The other thing that's very, very important, and do this before it's too late, is to set up a leveraged split dollar plan for your retirement. You'll have your own businesses, corporations, you can do this, but you have to be a C Corp to do it. What it is a glorified insurance plan. Uncle Sam doesn't quite recognize those yet. It's not a regulated plan, it's not a 401k, it's not a Roth IRA, it's not a SEP IRA. Don't do those. Uncle Sam is going to come in a couple years and take those to pay off the national debts. Don't do regulated, documented plans. My opinion. You set up a leveraged split dollar plan. Go through Prudential or a reputable insurance company, take out $1 million policy, you can stuff up almost $80,000 away tax-free a year. Whatever you can put away, you can put it into this insurance plan. A little bit for your premiums and a whole lot for a slush fund. And they'll let you usually put it in several different things, funds, zero coupons, treasury bills, whatever. It's pretty safe. And you can make 10, 20%, especially in the last year. The nice thing about it is if you want to retire, you want to buy a house, you want to add something to your office, you can borrow against it with less than 1% tax, which the corporation pays for. LSD, remember that, leveraged split dollar plan. And do it before Uncle Sam says, this is too good to be true, we're not going to let you do it. You know, the congressmen and senators don't pay Social Security. They have their own funds. When they all retire, they're multimillionaires. If you serve one term and then you get defeated, you get your salary for the rest of your life. Isn't that right, Michael?
Yes, it is.
They all retire multimillionaires. They don't pay Social Security. In fact, they've been stealing against that to balance this. That's where the surplus is coming from, that we so-called have. Any questions so far? Leverage split dollar, do it through a good insurance company. Prudential is one. That's who I did mine with. I'll leave it up to you.
What about PA?
Pardon me?
What about PA?
Professional association? You should do that, yeah. I have a PC, you have a PA. That's primary, but make sure it's a C Corp. Because with a C Corp, you write off everything. And that pays for this plan. Your corporation pays for this plan. Essentially what this amounts to is, Doctor, I'm your company. You're such a good employee. We want to keep you here. We're going to give you this benefit. We're going to set this benefit for you. It's a life insurance plan. God forbid you should die. We can use it to pay off the corporate assets. We'll give it to your wife, your family, whatever. And we're going to make your company, our company, pay for the premiums for you. Okay?
It's also best if all the equipment, the furniture, everything in your office is owned by another company, leads to your PC.
Right. That's what I said. It shouldn't be in your name. You should have it like a limited liability company owning your equipment.
Why can't they attach future earnings?
Yeah, and you shouldn't be too expensive. I think one guy, that's all he does, set my wife and I up with $2,500 for everything. Well worth it.
Chris,
Tim.
who would you suggest who understands this stuff?
There's a guy down in Vegas. I'll give you his number. Just fly down there, set him up, call him ahead of time, and he'll set up all your corporate minutes and set you up, LLC, the whole shot. Real inexpensive. Gregory Morris is his name. Okay? This is the best deal I've ever seen, and if you read the articles about it in Wall Street Journal and Business Week and stuff, this is the best thing for a doctor to do right now. And there's been some talk that Uncle Sam is going to have a window on this, so get in, grandfather in, whatever you have to do it, all right? Another thing I want to talk about, there was a group here, Tyler Encapsulations. Now we're talking science, okay? They have a product, calcium deglucarate.
Calcium what?
Deglucarate. I think this should be in your packet. If you have a wife, a loved one, significant other, female in particular, that has breast lesions, whether they be dysplastic breasts or breast cancer, you give them this. Start them on 2 capsules a day until you work up to 6 capsules a day. The urine will start to smell real foul, the more toxic they are. I have seen on thermographic imaging women with breast cysts and lumps disappear over months taking this medication. Science has known about this for 10 years, but it's a vitamin. We could have cut down the incidence of breast cancer in our society by using this simple calcium supplement.
What it does is it supports the beta creating extra bile.
You're ahead of me, but that's exactly how it does. Liver 1, liver 2 phases, glucuronidase, and it's very good for xenobiotics, the steroid hormones, especially estrogen. Somebody mentioned yesterday that maybe prostate disease in males might be related to estrogen, elevated estrogen compounds, and if you do some blood work, you can see this on some of the patients. It's probably good for us too, but it detoxifies your system. And in the last couple of weeks, as I've been using it on 2 females in particular, chronic fatigue has been very, very ameliorated by this, okay? So just more energy.
Who makes it?
Tyler Encapsulations.
1-800.
They're in Gresham, Oregon. Somebody have the number? It's 1-800-869-9705. Calcium deglucarate. D-glucarate. It's an anti-proliferative phytochemical.
And it's synthesized from oranges.
That's right, it's in fruit and foods, but primarily in fresh fruits and vegetables. And you can muscle test this on people. Some of the breast lesions, strong as an ox. They'll blow out on a breast lump and put this on them and just strong. So that's how I do it. Okay, please. Start with 2 capsules a day until you work up to 6. It says take 6 a day on the bottle. And you'll notice usually the urine will smell really foul for several weeks to a month or 2, and then as you clear up, the urine will start smelling better.
Is there a detox? People detox hard with it?
I haven't seen it. No, the first thing I've noticed was increased energy.
Apparently there's some other nutraceutical company that has a marker over Tyler on this, and so they are quelling. It's in Utah, a big nutraceutical company in Utah. And I guess legally they are stopping Tyler from doing any publishing of what they're doing for.
If you call Tyler, they'll send you a nice little packet of information, which I just make copies of and put it in the waiting room for my patients so they're aware of this.
How about cystic breast?
Exactly. That's great. Yep. Yep. Malignancies that may be susceptible. If you have somebody that had a cancer and their receptors are estrogen positive, then this would be ideal for that, okay?
How about metastatic spinal lesion?
Don't know. If they're, once again, if you think there's an estrogen problem there and they're being fed by estrogens and or those type of steroid hormones, that's what that's indicated for. once again, you could do your EAB muscle test and see if it corresponds to whatever, it's blowing out on. Okay. In your packet, I put an article, Systemic Dissemination as a Result of Oral Infection on Individuals 50 years of age or older, by Neva Zish, who's a dentist, and a Roseanne Mulligan, another dentist. Essentially, this article talks about patients who became ill subsequent to dental manipulation. We've been talking about critters for the last 2 or 3 days, everything from bacteria to viruses and things like that. But you have to understand, in my terms, that, and I'm sure Dave would agree with me, that he sees a lot of these little critters under the microscope when he does his periodontal surgery, and periodontal treatment, I should say. And I'm setting in my dark field to see what comes out of these cavitational things. And I'm sure, based on previous research, I'm going to see a lot of critters. When I send my path report to Jerry, as soon as I take the bone out, it goes in formalin. So whatever critters are in there, usually they're rapidly attenuated, But once in a while, on people who are really, really infected, it'll come back with bacterial colonies deep inside the bone. Now, in the past, I've cultured a lot of my lesions. I've pulled out 20 to 30 major microorganisms, okay, and some that were once considered non-pathogenic that are now pathogenic in terms of regular medicine, infectious disease. To do really accurate culturing techniques, you need to do it under carbon dioxide conditions, because these are anaerobes. As soon as you open it up, your culture is essentially useless. Unless you can make a small little window and stick a needle deep inside with like an 18-gauge needle or a 20-gauge needle and suck up some fatty fluids, serum, things like that, put that right into an aerobic culture and send it to the local lab. That's what I have done. Your labs are not equipped to think about these infectious diseases. They're not prepared to look at a piece of bone with 300 bugs in it. So it really doesn't make sense. And the point I'm trying to make is it's really important to send it for a biopsy rather than a culture and sensitivity. I've been criticized by other physicians. Doctor, you have an osteomyelitis and you didn't do a culture. Well, there's 300 bugs. Which one is the pathogen? We know pretty much, that it's staph and strep, primarily, or strep, but there can be other ones in there. And you heard earlier that we're finding fungi in here, and I think that we're going to find a lot of viruses in these cavitations, especially on people who have cold sores. And I think some of my patients and some of your patients that have recurrent pain after surgery may have what's called post-herpetic neuralgia because of the virus that's latent in that particular area. We know that the viruses, especially the herpes virus, likes to live in the dorsal root ganglion and come down when the opportunity is appropriate, when the patient's stressed, they've been out in the sun, had too much to drink or whatever. So you've distressed an individual with a surgical procedure. We know that Coxsackie virus, for example, lives in the third molar area. And these third molar Coxsackie viruses travel to the heart and cause a lot of problems with the heart, especially in the spring and the fall. And those of you who do muscle testing or EAB will find that. And you can also do cultures at that time or antibody titers and find that there are elevated Coxsackie viruses in patients with chest pain. For some reason, it's more appropriate in the spring and fall that these titers will be elevated. The point of this article is I want you to keep this for documentation. I'm trying to help you in case you go to court. I'm an expert witness on a lot of cases, and I know what the jury looks at. I know what the defending attorneys look at. I know what the plaintiff's attorneys look at. You need to document what you do. You need to biopsy what you do. You can do the ALT test with Dr. Haley. I think that's great. But after a while, they're all going to come back the same way. If the patient wants to understand if there's toxicity, by all means do that. Please cover your rear end and do a biopsy. How many people in here do cavitations now? Who doesn't biopsy? How come? And if you do a biopsy, give him a hunk of bone that he can look at under a scope. I've seen people, I've gone in on patients who have had surgery before by other practitioners, and there's a biopsy report from Jerry, and the specimen that was sent is like less than a half a millimeter in size. And so Jerry writes down, if I have to guess, I would say this is osteonecrosis. Now, I'm sure he's getting tired of my biopsy specimens because I'll fill a biopsy specimen. And it's all mush. Does anybody give you more dead tissue than me?
I've assumed you've been killing all this tissue.
Thanks. The size and the immensity of these lesions never cease to amaze me, so you just keep scooping them out. This article, I want you to read. I'm not going to go over with you. There's a couple of important things. Next page, page 2, brain abscesses. In 1981, Gallagher reported on a case of a 54-year-old healthy male who was admitted to the hospital because of the headache and involuntary twitching of the left facial and neck muscles. These signs and symptoms developed 14 days after a periodontal abscess surrounding the mandibular left second premolar. Was deeply curetted. This area was deeply curetted and drained, whatever drainage means. No cultures of the causative organism were performed, nor were antibiotics recommended post-operatively. The patient was diagnosed with a right frontal lobe abscess. Organisms cultured from the brain. Abscess included staph epidermis, Bacteroides, melanogenicus, and strep species, and Bacteroides is a known periodontal pathogen. The patient died 5 weeks after being admitted to the hospital despite massive doses of antibiotics. Now, I know we tend to be holistic here, but I'd kind of like to work for another 10 or 20 years without somebody taking my license. And I really encourage you to think about using antibiotics. Get in there, hit them hard, and get them off it. And if you're really concerned about toxicity from antibiotics, give them a homeopathic antidote. But please, these things are so virulent. These kill people. I see people every day who have systemic problems from their mouth. I had a patient last week who was sent to me with crippling arthritis. She couldn't squeeze my fingers in her left hand. She couldn't close them more than she can open a jar. When I took out the left maxillary teeth, including the impacted third molar, the next day she could squeeze my fingers and she can open a jar. That's overnight. Talking about this last week. What's the treatment of choice in dentistry for antibiotics? Come on. Pen V, right? How long have you heard that? Years. Tetracycline, okay. But let's say you're going to take out an infected tooth or a third or something, or you have an abscess. They tell you to take penicillin, right? Penicillin is the greatest antibiotic for converting a bug into a cell wall deficient organism. And for those of you who do dark field, you look under a microscope and you see all these little strange critters growing, it's probably because most of us have had massive doses of penicillin, especially those people who have had pre-medication for endocarditis, they have that mitral valve prolapse, or they have prosthetic valves or prosthetic joints or those kind of things. And this is where Dieter talked about yesterday using clindamycin. Clindamycin is a very effective medication. IV, it's wonderful. I see no side effects. I have seen people literally turn around from death's door in 2 hours on some IV clindamycin from chronic jawbone infections. I had a patient several years ago. I started working on him. Very difficult patient, overweight, wasn't breathing very well. He's wired to my monitor, and just as I'm ready to make an incision, he says, "Chris, I got chest pain, and the arrhythmia starts to show ST segment depression." Stopped the surgery. We had only given him a little bit of Valium, took him to the hospital. They kept him there for 2 days, couldn't find a thing. He says, "Get me out of here." I took him home with me like a stray dog, and wired him up to I did some muscle testing, put him on IV clindamycin. From a flushed red face to 2 hours, he was feeling normal, no more chest pain. It was from his jaw, and the clindamycin attenuated the infection. Didn't cure it, but it sure helped him get over it, and I was able to surgerize him the next day. Now, I know a lot of you can't use IV antibiotics, but I don't see why you can't, but I know you don't want to take that chance, but yes, sir. No, I haven't. But what you do is if you're going to put a patient on it, make sure they're taking good yogurt cultures and the spectrobiotics, lactobacillus acidophilus, all those things. And I have never seen that once they do that. You know, it's a great medication. And I use it, of course, for irrigation inside the socket, inside the cavitation, clindamycin. That's one of the ones I use. And remind me later, I'll just tell you my routine about the irrigation solutions for what I've been using lately, okay? Next paragraph under that was a 52-year-old female who experienced severe frontal headache starting 2 weeks after she underwent multiple extractions because of advanced periodontal disease. 3 weeks post-extraction, 3 weeks post-extraction, she was admitted to the hospital because of being febrile and experiencing severe periorbital pain. The diagnostic workup was significant for a cystic cerebral abscess containing enterococci
diphtheroids, and strep organisms. Despite IV antibiotic therapy, the patient did not improve until all her remaining periodontally involved teeth were removed. Within a week after the extractions, the brain abscess diminished in size and the patient's health returned to normal. The authors therefore deduced that it was the initial extractions which seeded the brain abscess. The remaining presence of severe periodontal disease continued to contribute to the abscess formation in spite of the antibiotic treatment. Point here is, number one, use antibiotics. Number two, some of your patients aren't going to get better until you've taken out all their dead teeth or all their cavitations. I've had several patients who came in with routine facial pain on one side. You take out a couple dead teeth, you think it's going to be no-brainer. Pain-free for 2 days, pain comes back here. You know you cleaned it out. I mean, you went to the floor of the sinus, you're very careful, all the dead teeth that in that area were removed. Nothing could possibly be doing it. So you do the lower. Pain goes away for a couple days, comes back. The last cavitation on this side, as I put my last stitch in, this pain went away. 10 to 15% of your population or your patients may have contralateral innervation. Just because you get failure on one side, come over to the other side and start doing some diagnostic injections and see if these injections will make this side better. Right? How many patients have you seen like that? Jerry? Pain. Okay. Some. Okay. Like to me, thanks. Okay, and it goes on to tonic-clonic seizures, but the point is, from infection. On page 3, there's one little article here, and I'm going to leave this one alone. It was in 1981 that Thornton and Alves published the results of their retrospective study of 139 patients with bacterial endocarditis. The patient's average age was 40 years of age, and age ranged from 1 to 79 years. 36% of the patients reviewed were 50 years of age or older. 22 of the 139 cases, or 16% of bacterial endocarditis, occurred in individuals who had a prior history of dental treatment or oral disease. Do you know somebody that doesn't have oral disease? The interval between dental treatment and the onset of cardiac problems ranged from 4 days to 8 weeks. Now, I wouldn't dream, a patient called me up and say, Doc, you did a filling on me a couple weeks ago, you took a tooth out, and that was like 8 weeks ago. Now I'm in the hospital with endocarditis, and I'm going to sue you. He basically has some grounds to stand on. I've had a couple of dental buddies of mine who called me, they had a potential lawsuit. I said, no, it can't be. 4 days to 8 weeks. Make sure in your history you ask the patient, do you have prosthetic joints? The same thing holds for those joints as it does for the heart. Do you have a heart murmur? Now, medical legal, you're probably best to prescribe penicillin because that's what the American Heart Association says. I don't. I use clindamycin. I use it IV right before I start my surgery. And I put patients on Cipro the night before. I start them the night before on their antibiotics so I have some degree of coverage. Only 5 of the 22 individuals with a history of positive findings of oral disease or dental treatment had been given prophylactic antibiotics. Strep viridans was the leading organism isolated from blood cultures of these patients. Viridan strep is the predominant etiologic organism in endocarditis. It is also the most common microorganism of the oral cavity and is frequently isolated from blood cultures after various dental procedures. The authors concluded that dental practitioners should familiarize themselves with those heart conditions which require antibiotic therapy prior to invasive dental procedures. I think a vial comes at 600 milligrams per vial. That's what I use. And it's getting very hard to get. And I'm not sure why. There's a couple things like that are really getting hard to get. Some of the anabolic steroids are getting hard to get. Decadurabolin, I used to get mine, nandrolone decanoate from Steris. The FDA went into Steris and shut them down. They were making some nice vitamins and things like that. I would suggest if you can load up on some antibiotics, and my thoughts are maybe with this 2,000 changes, you might find difficulty getting medications. I would load up on bottles and bottles of cheap antibiotics, especially if there's an anthrax scare, perhaps. I would get other things like plenty of peroxide betadine for sterilization. IV, you should have some IV peroxide made up as a general antibiotic. You have to start thinking about things like that. Okay. I use McKesson, General Medical. There should be representatives, and if you have a problem finding one, call my office, and my nurse will give you the general number of the company. Shine is pretty good, Shine Medical, and usually you can deal with them for deals.
Cipro is rather expensive if you found a way around it. Tablet is $3 to $4.
IV is not expensive, but you know, hey, so is a patient's life. How if they go to the hospital for 5 weeks? How much is that going to cost? See, you know.
Didn't the American Academy of Prosthetics or something like that change the recommendation for antibiotics for prosthetic hips and joints? Didn't they culture them and find there weren't oral pathogens there or something like that?
Don't know.
I think there may be a
I don't know.
change.
I get the latest one posted on my thing, American Heart Association, and it says
American Heart Association.
for joints you might want to consider for penicillin allergies clindamycin. They're not recommending erythromycin anymore. It's not strong enough. Amoxicillin. Wait, I'm sorry.
Where's the article from? It's difficult to read.
Um, Special Care in Dentistry, Volume 15, Number 1, 1995.
One more time.
Special Care in Dentistry, Volume 15, Number 1, 1995. And on page 4, there's a nice little chart here. It says oral and systemic conditions associated with a selected group of common oral microorganisms. So it gives you the pathogen on the left, gives you the oral findings, and it gives you the systemic conditions, where those bugs like to go. You might want to keep this around in your stack of articles for either patients to read or to cover yourself if you go to, God forbid, you go to court.
For anthrax, what are you looking at?
I think doxycycline, tetracycline is one of the indications. Yeah. And you can load up on that. It's cheap. Shine has, $250, $500 in a bottle. I think you're going to see these things disappearing from shelves. If I go to Costco in my town, I see cans of stuff disappearing now. Big packages of pasta, that kind of stuff. That stuff is slowly being taken up and bought. People are getting ready. Remember last year, Andy gave us a talk at the end of the year, Andy?
Yeah.
And I really think that he's really accurate in his assertion of what's going on with this year 2000. And I certainly would buy a generator for my office. You don't have to keep it there, but I would buy a generator to the office. You're in the middle of a surgical procedure and the lights go out. Got to have a generator, right? Got to have power. We haven't talked about viruses very much. I think a lot of pathology exists in our patients from chronic herpes viruses. And like I mentioned earlier, post-herpetic neuralgia, or pain in the face, is a very common finding in these patients. If for those of you who do muscle testing or EAV, or if you just want to do blood cultures, sometimes your testing will show you that a person may have pain in an area you're testing from herpes. And so I have some herpes nosodes, which I use muscle testing for, and I put it on the area, and if it confirms it, then you may want to think about using some acyclovir. You write them a prescription for acyclovir 200 5 times a day for 10 days. And you can put them on some BHT, which is from Twin Labs, beta-hydroxylated toluene, which opens up the viral coat and allows the immune system to do its thing. Those two things in conjunction seems to help a certain percentage of the people with facial pain. Anything else you can think of? Of course, vitamin C, vitamin A, that kind of stuff, homeopathic injections of antiviral medications.
Chris, there's some interesting published research from Aurora now, like in peer-reviewed journals on herpes infections involved in
I'm sure. And if you want to do a clinical study yourself, if you want to do some culturing on these cavitation lesions, save a little bit, put it in a little container, send it to your lab and let them do a PCR, polymerized chain reaction on that tissue, and they can tell you whether there's herpes in there. The problem is it's expensive, so try to have the patient's insurance cover it. So you're doing a culture, anyway. Okay? It's an easy way to do it. We can all do some research among ourselves. Please.
The cardiology literature shows that the herpes are found in the atherosclerotic plaques and coronary lesions. What would keep the herpes from being present in the smaller vessels that go into the jawbone, causing problems?
Sure. Where there's much more trauma here anyway. What other parts of our body do we subject to more trauma than this area here? Between the fillings, between the fluoride treatments, between the injections, between the surgical procedures, between the root canals. between just chewing, 20 million times a day, swallowing. And of course, based on that too, they're talking about chlamydia pneumonia as a coronary pathogen. And,
Found in the mouth.
and there's been, for sure, and there's been many studies, or several studies done now with people coming into emergency rooms with myocardial infarctions given by accident or Cipro. And those people survive better than the group that were not given antibiotics. So you got to start thinking about patients. Let's say your loved one has a stroke. You got to think about a hypercoagulability syndrome or a heart attack. Hypercoagulability. What causes hypercoagulability? Infections. Genetic predisposition to these things. And Jerry talked about hypercoagulability syndromes. I don't work up everybody with facial pain with these tests because they're very expensive, and most of the time they don't come out positive. But I've had a patient come in who had cavitations, and he had 2 strokes, and he was positive for hypercoagulability syndrome. So if you have a family history, for example, where you have a patient who had a stroke or somebody who's had peripheral clots or a lung infarction, somebody like that, you might want to think about working up for this hypercoagulability syndrome. And if you get your local lab to give you a lab book, there's a series of about 15 tests that they do to determine hypercoagulability, okay? Everything from cysteine to antithrombin 3, antiplatelet antibodies, plasminogen activator inhibitor, activated protein C, activated protein S. There's a whole string of them. And they seem to add on 1 or 2 more every year as they find out more about the clotting mechanisms. On the internet, there's some very interesting articles, stealth viruses. And the author is W. John Martin, M-A-R-T-I-N. He's an MD, PhD. And I'd like to have you look up some of this literature. It's very interesting. What's happening now is the viruses are commingling RNA and DNA. And they're coming up with new viruses, producing things like chronic fatigue, brain abscess, encephalitis. And you can see these things under a microscope, but it's hard to diagnose because it doesn't fit into the regular testing that they're doing for the antigens and antibodies. John Martin, MD, PhD. I just want to scare you a little bit, tell you what other things we're dealing with. I don't have it on here. Let me see if I can find it for you. I'll put you to work so you can find it on there somewhere, okay? There's a whole stack of literature. It's quite frightening, actually, but there's an excellent book that you should read if you haven't read it called AIDS and Ebola, Emerging Viruses by Horowitz. Horowitz is an ex-dentist. He got out a long time ago. He was smart. He's become a professional author. And he wrote a huge, thick book on what has been happening and how the CDC and the government has altered the AIDS virus. And it's kind of disheartening. Pardon? Created it. Well, it was probably in Mother Nature in the African green monkey. God knows how it got there, but that's where it started. If you buy a package of polio virus, which I did because I thought I had a patient with ALS that might have polio, so I wanted to make a homeopathic solution out of it. It says right on the box, cultured in simian monkey renal cells. Now, probably in that little sample, there's probably 40 viruses floating around at least, according to Horowitz. It might be more than 200. But they're showing up in vaccines that we're giving our kids.
He has a wonderful video
Yes.
on that. And we address the mandatory hepatitis B vaccinations that
Please.
are occurring right now. They're vaccinating kids before they leave the hospital upon birth.
Can you all hear him?
They're mandatory hepatitis B vaccinations with kids before they leave the hospital right now upon birth. And we just received a notice Friday that my daughter, who's going into 7th grade, now it's a state law in California that all children are to be vaccinated with hepatitis B. You see Horowitz's material.
No safe vaccine.
Yeah, there's no safe hepatitis B vaccine. It may have been used to transmit some other problems. You need to see the video.
The early hepatitises were awful. It gave patient AIDS because it was made from live vaccines from AIDS patients.
In New York.
Yep.
And Gulf War syndrome, very likely related to the vaccinations they were given.
Tom knows.
Chris, we scanned 317 military personnel with Gulf War syndrome. We found that every one of them had a root canal, and every one of them had really massive cavitations. The doctors down at the Air Force Academy Hospital where we them and said that, they were livid about the thing. And they think now that probably most of the Gulf War, not all of them, were, the injections, due to the cavitation immune system deficiency.
Let me make a comment on the hepatitis B vaccine in California. I happen to have researched that a little bit. It is circulated in the literature that goes to the school that it is the law that your children need to be vaccinated. In fact, it is not. It's a regulation. And in the regulation, if you read the actual text, the parent can write to the school and on conscientious grounds deny the right for that child to be vaccinated. Also, as a licensed personnel, a physician, for instance, can write a certificate to say that that child should not be vaccinated. And there is a section within the law that specifies that you have the privilege to do that, but they're not telling you that in the literature which is going through the school. And I have a paper trail for that which I've just said. This is a phenomenon that is occurring not only in America, but it's affecting all the states. And the mechanism is that the federal government is funding the kid care through recent legislation and inducing the states to go along with it, although technically it's unconstitutional because technically the states are in charge of health. One item of information that is of interest here is that the canton around Paris vaccinated the children about age 11 and 12 3 years ago against hepatitis B, and they have had 500 cases of multiple sclerosis. And the Ministry of Health of France has stopped the vaccination with hepatitis B for that reason. So if you don't like the idea of your child being vaccinated, you can say that a respectable authority, the Ministry of Health of France, has in fact withdrawn it for that reason, and you thereby won't get much flack from your school authorities.
Along those same lines, can't you draft up a letter saying, I will subscribe to the vaccine as long as you can guarantee that my child will not suffer any severe consequences to his health or nervous system for the rest of his life? I've heard some patients do that and have him sign that.
Logically, I'm with you that you will create a confrontation with the health nurse in the school, and if you simply want to avoid the vaccine rather than make a political statement, I suggest you say it on the health grounds and on these bases, and then you won't enter into a confrontation situation.
Chris, on that point, in 1979 to 1982, I remember the IABDM required that all dentists and physicians offer the hepatitis B vaccine to their staff personnel themselves. I heard it from back from two physicians, one from Harvard that asked for part of this was so angry because one of the reasons why the AMA does not want any physicians to be tested for blood is because of the liability factor in that open window when they weren't screening for the AIDS virus during that time frame. So I think it's really important that all of us review the impact of vaccines and vaccination on our members of our own family, things like that. So I thought it was really good.
No question. I think you're better off with the synthetic one. And when I was in school, I had to get it as an intern, but I took the synthetic form. Burden.
If you read
Hold on.
Horowitz' book, he says basically there is no safe vaccine.
He's right. He's right.
I wouldn't vaccinate my 11-year-old unless he had electric thermal screening, and then sometimes half a shot. But that's where you're safe.
Yeah. Are you going to give us information on that coming out of repair?
Right here. Next step. Patience, my son. Let me just show a couple slides that I have, and I'll get to this, and then we'll have our panel discussion, okay? Can you hit that for me, Mike? I got a new toy. This is a telethermography machine as compared to the other one you saw last night. This is based on temperature, infrared imaging. Turn this light off? Oh, I'm sorry. This is a form of thermography based on thermal imaging. I have a camera that's mounted, and I'm about 2 feet away from this individual's face. I can get images in black and white, or I can get images in color, and this is my color scale, with black being very cold at 31 degrees centigrade, and white being very warm at 42.9 degrees centigrade. This is a patient who was sent to us for hyperbaric oxygen therapy subsequent to oral surgery had done by somebody in San Francisco. And he came in for hyperbarics, which was making him somewhat better, but it wasn't improving his symptoms completely, and that was facial pain. To make a long story short, I edentulated whatever was left, went back into the original surgical sites and pulled out some more osteonecrotic bone, and this is what his jaw looks like about 6 months to 7 months afterwards. There's still many hot foci in his jaw, and his nose is very cold. Now, one point I want to make here, this gentleman was a smoker. Please don't do major cavitations on people who smoke. You're going to get into just a bastard of a case, and you have a tremendous risk for having that patient go into an RSD phenomenon. Who knows what RSD is? Dieter. Reflex sympathetic dystrophy. The reflex sympathetic dystrophy of the face is an underdiagnosed condition. It means that the sympathetics have gone crazy and have over-innervated this particular area, causing severe pain. But anyway, this patient has still a lot of pain in the jaws. I'm getting some bone growth, but he still has some residual pain in the jaws. Now, when I muscle test him, he shows that the osteomyelitis is gone. He's had surgery and hyperbaric oxygen, which helped him tremendously, but he still has this inflammatory reaction in his jaws, and all of the lymphatics are lit up down his neck. When I muscle test him, he shows up positive for Lyme's disease. He has spent most of his lifetime in the woods of California. He's got a cabin there. He's been a hunter and fisher, and he remembers many tick bites, and he's had many dogs. This is the other side of his face, more of the same, multiple hot foci. Now, I sent cultures of his blood, and I sent several teeth and tooth fragments to Dr. Lyda Matman. Dr. Matman is an 82-year-old Nobel laureate in Detroit, Michigan, who is associated with Wayne State University. Some of you are familiar with her book, and that's called Stealth Pathogens. And this is available from CRC Press, Boca Raton, Stealth Pathogens. And she cultured Lyme's colonies in this person's jawbone and blood. This is a fluorescent immunobody test. Now, here's the state of this particular disease. Lyme's disease is epidemic. Everybody has accused me of overdiagnosing cavitations. Well, I overdiagnosed Lyme's disease. For every one individual diagnosed, there's 10 more. When I can show in the blood, that's pretty good confirmation. Most, I shouldn't say most, a lot of testing will not show up an individual being positive, and you'll get your test back, they'll say negative, but they'll caption that and saying, but a negative test does not mean the patient does not have Lyme's disease. If you have a young individual with weird neurological symptoms, that's Lyme's disease until otherwise proven, something else. A person with bilateral Bell's palsy is 100% sure of having Lyme's disease. Unilateral Bell's palsy is 50-50. This is a disease that you're going to see in your office. I want you to think about it, and probably some of you have even cultured this out of some of your cavitational lesions. He's been on multiple antibiotics. He feels better when he's on them, but he feels worse when he's off them. Lately, I've resorted to some other medications like peroxide and some O3, and we've been making a vaccine for him. This is a colony of Lyme's organisms in his blood. This is a patient who I did cavitations on, did 4 cavitations, chronic fatigue syndrome. Not much facial pain, chronic fatigue. In my muscle testing, using my testing kit, she showed up as having Lyme's disease. I did some simple regular blood tests, the ELISA tests in the Western blot, they were negative. I put her on antibiotics. Biaxin, 250 milligrams twice a day for 6 days. And then I have her send her urine on the morning of the 7th to a laboratory in Palo Alto, California called IGENEX, I-G-E-N-E-X. They have an 800 number. They will send you the test kits. You want to do this, you want to do a Lyme's challenge as much as you do a DMPS challenge for mercury, the same principle. You want some die-off of organisms. You want them to show up in your urine. This has been the most accurate test for me so far. This has been showing up positive when the Western blot and the ELISA test is negative. Right there. IGENX, I-G-E-N-E-X. They're in Palo Alto. Tell them you heard Dr. Hussar, and would you like to have them send you some Lyme's urine antigen test kits and their catalog. They have some very specific testing for a lot of different things. Now, another thing Mother Nature has thrown at us, some people with chronic Lyme's will also, the tick that carries the spirochete, Borrelia, will also carry two more critters called ehrlichiosis and babesiosis. So you have to consider that in your diagnosis. Ehrlichiosis, E-R-L-I-C-H-I-O-S-I-S. Babesiosis, B-A-B-E-S-I-O-S. If you punch in Lyme disease on the internet, you can download about a 30 or 40 page article by Barashano, who is an MD internist from out east that treats a lot of Lyme disease similar to myself. And he has some really good articles and making some suggestions for treatment. And you can, of course, add your own methods to that. If you send for the IGENX catalog, they will send you a nice catalog. We'll give you a nice review of the testing and the critters and some even nice pictures in there. Those of you who do dark field analysis can oftentimes see these little spirochetes going across the screen on patient's serum blood, which is a tip-off. This is a frontal view. This is the patient showing some very cold areas in the front of the mouth. This is the upper lip here, and there's his nose. And this is a month later. We've got some increased blood flow here, and the nose is almost as cold, but there is some increased circulation based on the use of some IV peroxide and ozone. This is a woman that was sent to me who's had several cavitations done in her jaw, lower right side, severe pain. She had this very demarcated band on her face. This represents necrosis of the bone. And I believe it also represents a little low-grade sympathetic phenomena where you have this ischemic change secondary to necrosis. We've operated on her, and she's gotten some substantial relief from the surgical procedure. She had osteomyelitis. She also complained of pain down the right arm. Look at this demarcation. Essentially, it's the head of the bicep. This whole bicep tendon is inflamed here. It was not related to the cavitation surgery because it wasn't ameliorated by the surgery, but she lives in Malibu, California. She has Lyme disease. Lyme disease is epidemic in Malibu. The hills are covered with ticks. Now, while I'm on this subject, I just want to tell you what other things thermography is good at. If I wanted to do thermography of her breast for lesions, dysplastic areas, or malignancy, if she showed up as having a hot spot on the breast, and I challenged her hands with some ice packs, and that area that was hot or delineated didn't autoregulate, chances are that lesion is a malignancy. Malignancies don't autoregulate. If it does autoregulate, chances are it's some dysplastic tissue.
How did you do that muscle testing? You did that, right? You did that muscle testing?
No, thermography.
Oh, thermography.
So for example, I would do her breast, and if she's complaining of a lesion, then I would say, okay, let's do a baseline, then have her hold some ice packs or immerse her hands in hot water or cold water. There should be a lot of generalized vasoconstriction, and there should be some autoregulation of the tumor. Of the lesion. If it's a tumor, malignant tumors don't autoregulate. They've gone beyond the regulation of the autonomics. And that's why I think, and I think Dieter will agree with me, that some malignancies, or maybe most malignancies, have some in partial to autonomic dysfunction. And most of you know that Dieter's worked with prostate carcinoma, and PSA levels will come down with autonomic treatment. All right, we're almost done. And then we'll ask some questions. And would you turn the lights on, please? This is the little device I talked about yesterday. And I have to admit that I'm not a great homeopath. I've had some training, but I'm sure most of you can make me look like a piker. But I have a patient who's a veterinarian from Minnesota, and I did some surgery on he and his wife. And he said, "Are you familiar with this little device?" And I said, "No." And he showed it to me. It's called BioPet. It's got two little paws here. And you can duplicate medications, or you can make homeopathic remedies. And it makes them in dilutions or powers of potencies of 4, 10, 30, and 200 electrically. For example, in our particular case, you can take some cavitational material, put it in this well, either in a sterile test tube with a cotton pledget, and you can have a homeopathic alcohol here, or any homeopathics that you use, or you can have B12 here, and you can theoretically, according to the manufacturer, potentize your lesional material here and make a vaccine out of it. And if you go through some of the literature on cavitations back at the turn of the century, they made vaccines from the cavitational materials on patients. And I do that occasionally. I'll take some scraping, and as I told you yesterday, I'll put it either on this device here or in a test tube with a little bit of grain alcohol and some normal saline, and I'll bake it under a UV light, and then I'll inject it back into the patient, and then I don't know if it works. If you muscle test, it seems to be strong, but it seems to help the patient. But if you look at the literature, it's there. Something to think about. They provide you with a little booklet, and they have a series of 30 little kits here, 30 little testing vials, and these contain things like sinusitis, colds and flu, skin inflammations, diarrhea, vomiting, urinary tract infections, chronic infections of the jawbone, herbicides, insecticides, dental abscesses, and you can either copy those or make your own. Something to think about. I do. And you can get this from Dr. Dehaan, capital D, small e, H-A-A-N. He's a veterinarian in Minnesota, and his number is 1-218-846-9112. They're $3.99 for everything, booklet, testing kit, and they even have one for medical too. But I think this is all you need. 218-846-9112. Mention my name so he knows where it's coming from. Biopet, B-I-O-P-E-T. It's just a homeopathic potentizer. X. Yeah.
What potency do you most frequently use? Just muscle test?
This makes it. I don't have a say in this. It's 4,
I
10.
know, when you make your vaccines, what
I
comes up?
don't do that. I just make it and draw it up out of the tube. I don't strengthen it.
Ah.
Okay. I don't succuss it. I've been doing that with Lyme disease too. Taking blood out of the patient, mixing it with a little bit of Lyme's antigen, baking it, put it back in the patient, and you'll get usually a reaction here and their joints will hurt, which kind of confirms they have a disease. I'm trying to stimulate the immune system to wake up to see the bug. Most of these organisms that you saw here are pleomorphic. They're L forms. They have no more cell wall. They've been disguised from the immune system. The immune system can't take care of it. You have to wake up the immune system. And that's part of the problem with penicillin. We make cell wall deficient bacteria, which becomes immune to our own immune system. Questions?
Just a comment, like the two German dentists who developed all of the electroacupuncture concepts around the teeth, Dr. Kramer and Dr. Chirk. They're still both alive, and they were in the team with Dr. Wall who developed the electroacupuncture. There were like really 3 guys that together developed all of that, and the dental part was just developed by those 2 guys, and they were the 2 leading guys operating the jaw cavitation since the 1950s. And still today, in their teaching, they never do any cavitation without following the work up with giving a homeopathic antidote made of the material that came out of the jawbone. So as an auto vaccine, like Hussar's called it auto vaccine. And we found, like by me, when I worked with Chris, we did a few, where we hand succussed the products, and we found really no difference between electronically preparing a sample, which of course takes a few seconds, versus by hand succussing it and making it up and testing the proper potency, which takes really hours to do.
Yeah.
And so I do recommend that out of this group, I would wish a few of you would buy this machine so we can get some collective experience with it and see what your guys' experiences is, and then if it is really a winner, like it seems to be. I have a different machine from this one, so that's where my interest is. We want to find the best and least expensive machine that does the job, and then see what your experience is, and then get back with us and let us know what you experience, because they have statistics in Germany, published work where they've showed when they follow-up cavitation work with the vaccine, the healing is 80% better than when they don't do it. That means many of the failures that we see in this country, and many of you are in the world of this know that cavitation work often is temporary improvement and then they relapse. It's because we don't follow it up with the vaccine. So I don't think it's a small thing. I think it's a big step. I but we need to gain that experience collectively, I think, to get quickly to a good point.
Andy?
I think basically these machines are really good, and I've used them for a long time, but the classically prepared remedies work a hell of a lot better. They last longer, and the machine prepared remedies will relapse. I mean, not the remedies, but the patient will relapse
Okay.
every time. Whereas the classically prepared remedies will erase the image that's there much more clearly.
I have taken some material and had Stu Russell's company, PHP, make it, and it's marketed under my name, Medical Dentistry. But you might try that as far as more of a classically made one. They hand-succuss it, I believe. No, we come here and give you our pearls too, but we expect pearls back. So, we kind of meet and we're going to ask you what you're doing with all these things. But are there any questions? Somebody had a question about anesthetic? Michael?
Yeah, Chris had that one. You touched on anesthetic a little bit, and I was just kind of curious your protocol, because that does come up as far as...
First of all, I don't think there's any place in dentistry for a vasoconstrictor. That's where all your reactions come from on patients. And they say, God, they come in and say, I'm allergic to epinephrine. You can't be allergic to epinephrine. It's in your system. But you sure can be allergic to it if somebody puts it into a vessel, or at least get a reaction to it. That is probably, in my eyes, and Jerry alluded to it earlier, that one of the major causes of osteonecrosis. I mean, how many places in the body get shot with epinephrine? The mouth. When you're doing surgery, there's 4 places in the body that you don't use epinephrine: fingers and toes and penis and nose. You don't use epinephrine there because they're end arterial systems. Well, basically, this is an end arterial system, especially in the retromolar areas and the tuberosities in the back. So epinephrine is really not indicated in those areas because you're going to cause necrosis. I use primarily Marcaine in my surgical practice. I buy large vials of it. It's relatively inexpensive. I use 5 cc syringes. I draw it up in an 18-gauge needle, and I switch to a 30-gauge needle and use my injections, and I inject very, very slowly. I don't like to shock the body, okay? In fact, what I've been doing lately is taking a little Procaine, buffering it with a drop or 2 of bicarbonate, numbing the area first, waiting for a couple minutes, and then going through the numb spot with Marcaine. Patients feel very little pain. It's just a nice way to pre-numb and then do your blocks, okay? Now, I had a patient last week that was allergic to Marcaine, but I found out after the fact. So I went to Duranest. I have all the local anesthetics in a test kit. Duranest, I have Etidocaine, which is Duranest. I have Marcaine. I have Lidocaine, Procaine, Citinest, Prolocaine. You muscle test those. But if you're going to be doing surgery for a couple hours, you want some real long-lasting relief, and you want to use either Marcaine or Etidocaine because they're the longest-lasting ones now. If you want to experiment, and I've done some of this, and there's been some articles written, I play with morphine injections, I play with Demerol injections, and I play with ketamine injections. Now, those of you who do a lot of pain work, if you've been doing some studies, they talk about deep pain receptors in the brain called NMDA receptors. There's 2 things that we know that block those receptors now. One is dextromethorphan, which you can get over the counter, cough medicine, or ketamine. Ketamine is a dissociative analgesic. From here on up, you don't care about anything. You can do anything you want down here, but I'm out of here. It's wonderful. It's safe. The only thing you don't want to use it on is somebody with hypertensive, because patients take off and they get a little hypertensive and a little tachycardia. So you never use it on that. But you can use it as a general anesthetic in your practice and do it by local injection. For example, when I'm working on an area and it's blocked and you can't get it to sleep. Now, who hasn't had that happen? You take a little ketamine in a syringe and you put a couple drops up there, and that will stop the pain instantly. And it's safe. You cannot depress the cardiorespiratory centers. It's almost impossible to overdose patients, and they're using it in the ER in children that come in for doing sutures and stuff. By the time the patient's waking up, the suture's done, and you're out, and the patient's out of there. Are you all done? Ketamine. You can buy it in vials, 50 milligrams per ml or 100 milligrams per ml. I suggest you do the 50 to start with. Yes, sir.
I also use ketamine in large quantities. The gastroenterological literature claims that it should not be used for endoscopy because it increases the irritability of the larynx. That's the one situation where conventional medicine for light conscious sedation is not used. Have you had any
Nothing.
laryngeal problems
Nothing.
related to the lab?
No.
So that's another bit of disinformation.
Yeah, it's very safe.
What's the onset you're getting on the Marcaine?
About 5 minutes. That's why I use the Procaine first, and that gets done within a minute. And then I use Marcaine through that wheel, essentially, I made, okay?
Right.
Yes, sir.
Commented question. Ketamine is also useful topically for post-herpetic neuralgia.
Really? Well, I use it, mix it with DMSO.
Yeah.
It becomes more useful.
DMSO or something
You
like
can use it IM, IV, sublingually, and what I suggest that you do is buy a bottle, get a quiet space at home, and put maybe 3 or 4 cc's under your tongue, and let it sit there for as long as you can and experience what ketamine is like. It can be very, very useful, especially on patients who have very, very deep pain disorders, and you can actually talk them through it and get it out of there. If you have a little time and a little know-how to get them through stuff, this pain is now gone. You don't have to have this anymore. It's very useful for that, especially when you have a little pre-medication with Valium. Do you use Valium prehand?
I mostly use midazolam.
Okay. If you look at the literature, you can get some psychotic reactions with ketamine. However, if they're pre-medicated with Valium, they don't have it, and it's a wonderfully nice trip.
How much do you inject when you can't get a blood?
Half a cc most, 50 milligrams.
Topically.
No, just right around the tooth. You can do it into the bone, into the tissue, in the gums, infiltrate. All the above. You can use it anywhere. You could probably use it rectally if you had to do an emergency or something, but I mean, it gets absorbed through the mucous membrane.
Sublingual was great.
I have, on patients with chronic facial pain, I think maybe has some sphenopalatine neuralgia syndrome to it, I buy some spray bottles, and I'll take some Procaine, lidocaine, Marcaine, and ketamine, little DMSO, put that in solution, and say, here, spray this 5-6 times a day. Go ahead and use it. Try to get it back there in a sphenopalatine ganglion to knock out that deep-seated pain. If you want to have somebody comes in who's a little nervous for their dental surgery, put a couple drops of ketamine under their tongue before you start working on them. Sublingually. You don't even have to inject it. And they get feeling pretty good, and they get out of there and they drive home. If you're doing a heavy case, then give them some Valium IM or orally beforehand. Have them do 10-20 milligrams of Valium before, an hour before. They're really nicely relaxed when they come in. Then you can use the ketamine, and you won't get any psychotic reaction. There's a lot of good material on the internet on ketamine, but it's very, very safe.
You can use
I figured
kava
you'd use
for
that.
Too, though.
Pardon?
You can use kava an hour before, 2 hours before.
I need it now.
Well, you're giving them Valium an hour before. You can give them kava.
Oh, I see.
Non-toxic,
Same,
no side
okay.
effects, cheap.
Mike?
There's been a few issues around the canes converting into aniline, and one's worse than another, and your Dieter might have a comment on, has anybody found the antidote to that? It's like, what pulls it out, what eliminates aniline, and kind of what is aniline, and
Theoretically,
what the risk of it is if you're doing a lot of neural.
Theoretically, you could use a homeopathic dilution for your lidocaine or Procaine. I don't know how to prove it. Or, I mentioned earlier, you can use for your nerve blocks, you can use ketamine, morphine, or Demerol. Demerol tends to be more vasoconstrictive. Morphine tends to be more vasodilative. They kind of tend to watch you if you're ordering a lot of morphine. But it really works nicely for a nerve block.
First of all, I think a lot of the information on the toxicity of the canes is disinformation.
Yes.
Disinformation, because
I agree.
the only articles that really were was on the toxicity of the lidocaine or the possible cancer link with lidocaine. There was no other peer-reviewed literature on any of the other canes. So I know it's a dentist here in California who kind of spread the news on that one. And I think it's a little bit like an exaggerated Y2K phenomenon. So we don't have to be, I believe they're concerned about it. I am concerned about lidocaine because of the literature. There's been a couple of studies now trying to refute the lidocaine and cancer link. One of them looked pretty good, but that sort of still is in the air, that lidocaine may cause cancer. But I think the other things, I just contacted him and asked him for the literature he has, based on the stuff, and it says really his own theoretical considerations without any research whatsoever, clinical research, in vitro, in vivo, there's nothing that supports that. So
There was one paper that we came across. Remember in Santa Fe, I showed it to you? Yeah, there was lidocaine. There was one paper. It was a brief. It wasn't a whole study, but there was one summary that I got. So you might want to think about, I don't know how you deal with RSDs. If you need a local anesthetic to deal with RSDs,
comments. One, 2 weeks ago, Thomas Rouse said that the lidocaine and cancer link had been pretty definitively refuted. That they actually went through each of those cases.
It's been refuted, you said?
It's been
Okay.
refuted. So at this point, at least according to Thomas Rouse of 2 weeks ago, there is not thought to be a cancer link with lidocaine. The other thing is someone brought up laryngospasm with ketamine. Ketamine is actually an indicated general anesthetic in the setting of asthma.
Yep.
When you intubate an asthmatic, ketamine's your first choice.
Yep.
And so for people who seem a little bit, scary, that would actually be a good drug.
Mike?
Does the Academy have a membership list and location of all the doctors that come to the Academy meetings? Because we frequently are faced with a lot of referrals from people.
I think it's in your packet there, I think.
Is there one?
Yeah, I saw one of mine, so.
Is it just this meeting?
Yeah.
And it's not arranged by state or anything, it's just out?
No, I'm doing that at my office. I try to have some cards and stuff from different states, so.
Mike, there's not a good list. There are not enough biological dentists that you can be confident to refer to. So you can call and we can try to give you the names that we have, but I always try to give more than one, because unless you're at the point of the drill, you don't know what's happening.
Thank you, Carol.
Let's open this up to a question and answer period, and we'll get the panel up here, and we're going to ask you some questions and vice versa. Who knows what the textbook? Sure. What do I do when I do surgery? This is what I do. I bought one of those pressurized bottle systems that runs off my compressor, and I fill it with sterile saline for irrigation, and I have a hand syringe, and I put a couple shots of peroxide in that to keep that even more sterile. So I'm using that for my irrigation to cool off the burr. I then, when I think I'm all done surgically, I take a 20 cc syringe with a blunted 18 gauge needle, and I take a dilution of peroxide 50-50. It's diluted 50% with normal saline, sterile. And I do high pressure irrigation. High pressure is, I don't know if it's more important than the peroxide or not, but high pressure. I usually use 1 or 2 syringes full of that. Then I take betadine. It's diluted like usually 1 to 10. 1 betadine, 10 water. Same thing, blunt needle, irrigate hard into the bone cavitation, the surgical site. Then I take a 2x2 gauze and I mix a combination of DMSO, EDTA, and DMPS, and I saturate that gauze with that inside the bone cavitation. And the reason being, those pictures that Jerry showed you, that chalky bone, I see that a lot. You have to get that out. That chalky bone is dead. So you can shell out underneath and get, you'll see it more inside, as was demonstrated on his slide, that chalky bone. And the periosteal area on top is usually pretty good, so you clean it underneath until you see bleeding underneath that chalky bone. That means that bone will survive. I pack it with DMSO, EDTA, and DMPS, primarily for, I think there might be some metals in there. The EDTA seems to etch the bone so you get better adherence of your flap when you close, and it seems to make the bone bleed a little fresher. Okay? Take that out, pack it with 2x2 gauze again, which is now saturated with clindamycin, vancomycin, and gentamicin, and a little bit of amantadine, liquid amantadine, which I have made up. It's an antiviral. I either have liquid amantadine or acyclovir. And I saturate that for 5 minutes. I'm killing viruses, I'm killing bacteria. I'm sure I'm killing fungi with the betadine and the peroxide. I don't know what else to use, And then I take it out, and I take a look and make sure everything is bleeding well. There's little punctate lesions are bleeding. I have nice red blood coming up through the whole area, and take my flap and close it back up, my usual procedure. Sometimes I'll use collar plugs if I want to build up a little bit of bulk. If I'm close to the maxillary sinus floor, I have a perforation, I went after a mucocele or something, I'll take a collar plug and wrap it with collar tape, put it up against the floor of the sinus, and sew it very tightly that way. Try to avoid an oral antral fistula. Okay? I've used it down in Texas once. I haven't started using it. It might be very useful. Emdogain. It's from Europe. It's a derivative of pork. According to Bob Jones in the Cavitat, it really seems to accelerate bone growth.
We've seen as much as 80, 90, 95% regrowth of cavitated areas within 6 weeks.
EMDOGANE, or GAN. I'm going to probably try to get some of that. Emdogain. EMDOGAN or GANE. JIN?
EMDOGAIN.
GAIN. Emdogain.
embryonic tooth growth factor origin.
It may be very, very beneficial.
It is FDA approved.
Yeah.
And who has it?
It's from Europe. I don't know.
Biogen
We can call you Bob.
yeah.
Chris,
I got it on my webpage.
the Germans just come in and talked about flushing the air with what's called ozonated water. Have you tried to
Yes.
how's that worked out?
That's okay. What I do lately now, instead of doing that, I've sewn it all up. I take a glass syringe. I take gaseous ozone, put it right in the middle of it,
Inject the site.
right into the site.
Tell the patient it will smell sweet.
What?
Tell the patient when you do that, they're gonna get a sweet smell.
They're out. They're out.
I stay away.
Let me make a suggestion. You know, if you're going to do something that's a little iffy, don't write it in your chart. Don't write that you injected Sonum remedies or something in there. You know, Uncle Sam doesn't like that stuff. If you get sued or something, what's the normal treatment for osteomyelitis? Open bone biopsy, surgical curettage, antibiotics, hyperbaric medicine. That's the standard protocol. What you do on your own is your own thing, but don't dictate to an attorney how he's going to crucify you. Be smart. And biopsy everything. Stick with, you know, if you have to go to court, say, here, I did everything according to the book. Then whatever you want to do on your own, that's your own thing. We're all innovators in here, that's fine. As innovators, expect a lot of arrows in your back. Because people come back to you, you know, and they say things behind your back about things you've done, especially attorneys and other doctors. So don't be dumb. This is really, really hard work. And there's people, you're the deep pockets, don't forget. And now there's attorneys out there that are starving to death. In Reno, they're making announcements on TV all the time. If you've been harmed by your doctor, let's chase some more ambulances. That's all I have time to do. Protect yourself and never guarantee anything. You're not going to cure somebody's MS. Or you're not going to cure their back pain. You're just going to take some dead bone out. That's all you have to say. But you said this. And you know, the best thing to do, and I haven't done this yet, but I'm going to, when you sit down with a patient before the surgery, you go over everything, it's for the informed consent, have a little video camera going there. Mrs. Jones, do you understand that we're going to go inside your mandible here and take a mandible and show them? We're going to go inside and clean out this. We'll be taking some cultures and some biopsies, and we're going to sew it up, and this is what you're going to have. Put it on a videotape, and in case, you know, 2 years down the road, she says, you didn't tell me that. Wait a second. Monday, January 22nd, 1995, we saw you, and this is what you said. It's on the videotape. If they don't want to do that, don't be afraid to dismiss a patient. If you think if you smell trouble before you even start, it's worth it to get rid of them before you even start. I don't care if you have a Porsche payment or not. Don't touch them. And really look twice at smokers. They won't heal. Especially smokers that have been on corticosteroids. You'll get an RSD in the face, and then you'll be married to them. Any questions? I use that after surgery. I pump them through amino acids and IBC at the same time. I want some anabolism. That's why I use amino acids. Free amines. 8.5%, 500 mLs, glass bottle. And about 25 grams of vitamin C, trace minerals, B complex. Lately, I've been on my IVs before I start my normal saline drip, you know, KVO with my antibiotics. I put 10 cc's of Procaine in there to stabilize the myocardium and stabilize the patient. And I would suggest, even if you just use local anesthetic, at least get yourself a little pulse oximeter and put on a patient's fingers so you know how well they're breathing and you know what the heart rate is. Cover yourself. Just look. This is such dangerous work. You can't believe it. Even under local anesthetic. This is serious medicine. This is medicine. This isn't dentistry. This is medicine. You are affecting people's lives. These chronic infections destroy lives. Dentistry kills people. I'm sorry to tell you that because you're my brothers, but I don't, you know, I see, I have patients that come in, they've been to their dentist, the dentist can't even read x-rays. They put crowns on dead teeth. Oral surgeons miss chronic infections in the jaw. When you see these loculated lesions that are as big as your thumb, there's nothing wrong there. And the nerve is breaking down, degenerating, demyelinating. There's nothing wrong with you. You have a Prozac deficiency. You have a Valium deficiency. Let's bring the panel up. Make it quick.
I just want to caution a lot of the dentists in here, and I'm not going to point the fingers on things, but there's some very experienced surgeons that are doing cavitational surgery now in our group. Chris, by far, has got probably more experience than anybody. But I do a referral service all the time out of Denver. On my webpage, I get calls, 5 to 10 calls a day from people that are seeing dentists, not necessarily this group, but other things that are got major problems. And one of the first things they say is, I start doing referrals to some of the guys that are doing this and gals that are doing this stuff right. And they say, oh, I don't want to go to him. My dentist and my doctor says he's a butcher. He just takes out too much stuff. And you know, we all know that if you don't get necrosis, gangrene out of the bone, it's not going to heal. And so the first thing I've got to do is calm that patient down and get them into the right person to get them well. So don't go knocking some of your fellow academy members here when they're doing it right, okay? Because that doesn't help the patient at all. And it sure makes it tough when I'm trying to refer them to the qualified people that can really make them well. I mean, the people that have pioneered this stuff, we know what's going on in there, and they should be respected. And if you've got any problems, Chris runs a training deal for doctors and dentists that want to do this surgery, and you can talk to him anytime. He's glad to take you under his wing and show you how it has to be done to do it correctly, and stuff. And I get all the time where the patients have said their dentist is knocking or their doctor is knocking the way Chris does his work and some of the others.
Bob,
Yeah.
I think the major problem that exists in the cavitation area right now is some way of having a definitive biofeedback mechanism to determine when you remove all the contaminated bone. I'm hoping that your instrumentation, because to learn the EAV techniques and whatever techniques that a lot of us old timers have utilized to have successful cases, is not so easy to teach in a 1 or 2 day course.
Well, that's true, and it's a tough situation. Every type of instrumentation we came up with on anything is a compromise on something. Now, Cavitat is the best it's ever came down the pike. Everybody that's used it says the same thing. It's going to revolutionize the way we do this surgery. It's got its limitations. It'll show it down to 25 thousandths of an inch. So when you get down to the point that if you got the Cavitat, you can, and you've done this surgery, take another 25 thousandths out.
Right.
I mean, that's the only thing I can tell you. That's the safest way to do it. But if what I'm trying to do is preach unity, guys, we got to do this stuff on protocols that are accepted by the academy and accepted by the seniors in this group that are doing this stuff right. And we've got to follow those protocols. If you don't, you're going to end up in court with the board taking your license. Now, fellows, stick together, man. There's not enough of us out there now.
Thanks, Bob, you're right.
Now, this was the crowd there was.
As opposed to the one-fingered hand they frequently get.
Hey, Chris, you want to be the moderator? We're just going to get started. John, you go first.
Yeah, I think this question is strategic here. The mic is right behind you, so whoever's going to speak to the mic. You want to use that too?
I think everyone had a good time. I especially want to thank my wife Carol and her sister Norma for helping us. Number one, because Norma admitted if we decide we're going to do this again. And we've been doing it every year for the last 13 years. So it's probably will do it again. Thank you all for coming and putting it here. That's what this is, an open forum place. A lot of new faces this time, and some of the older ones. So we'll see all of you back here, hopefully within a year. Bye-bye.
Thanks, Ed. Let's give them a round of applause. Thanks, Ed. So I think John already had the first question, and she was next, and then you. Yeah, John.
In regard to tonsils now, can we kind of summarize how you do energetic testing and when tonsils are
That's fine.
retrievable or when they're irretrievable?
Yeah, John is asking a question: how do we decide when tonsils need to go, or when we can save them? And I don't have a definite answer for that. You know, with the tonsils, like I said yesterday, there's 4 different kinds of focus. You know, the tonsils are neurological focus. It means they're affecting the nervous system. You can always find it with EAV or with muscle testing. But if it's a toxic focus, then the challenge looks like what I did yesterday with the tooth. You have to either inject it with Procaine, the tonsils, or shine a laser on it to create some drainage from the tonsils out into the lymphatics, and then see which part of the body lights up as a response to that. And then against those areas that show up, you test with the nosodes and with the resonance phenomenon and see what resonates with that. If it's dental toxins you find in your low back, or dental toxins you find in the knee joint that's been a chronic problem for the patient, then you can say, okay, this tonsil has become now a focus on its own that stores and multiplies the dental toxins or other types of toxins, and from there seeds into the problem area of the patient, and then you can say, yes, I suggest they need to be removed. And it's been very, very successful. The other thing with the tonsils is, when in doubt, really everybody we've sent so far for tonsillectomy has had some major clinical improvement. Sometimes not in the area that we suspected, but there was some, one guy, we sent him in for prostate cancer. The prostate cancer went on unchanged, but his chronic depression completely went away. And so, it's like, when in doubt, they should come out. Just with the teeth. I mean, it's the same with the teeth. I mean, like, how many of you can honestly say, every time we examine the tooth and we kind of go for all the stuff that we know, and then we predict, okay, well, if you do these 3 cavitations, so then your hip pain should be gone, and we do the cavitation, the hip pain is still there, but the patient feels 1,000% better, It doesn't mind his hip pain anymore, because it's just, he feels so good otherwise,
Peter, I quote, when in doubt, take it out.
Yeah.
99% of the time, let me tell you, and the patients have taught me that, say, Doc, I don't care what you tell me, I don't care what your meter tells me, anything else, that tooth's been bugging me for a long time. Take it out, chop it in half, and instead of seeing a nice red healthy pulp, you'll see a gray ischemic pulp with dystrophic calcifications right around it. That chalky stuff that Jerry was showing on the slides in the bone, the inside of the tooth. And it was going to die 6 hours, 6 days, 6 months down the line. It's dying, and it's a focus.
In thermography, we have any kind of reaction that you see between the first and second on the tonsil point is showing there's some life force doing something, like showing or reflecting its ability to either inflame or become hotter or become colder, so that you can prioritize how important that is, both by it being absolutely fixed or blocked, and that's a point to consider surgery, and then you do a third measurement with injection. So it's a clear prioritization you get.
Asthma patients really respond well to tonsillectomies. Remarkably.
In doing the EAB, electroacupuncture, electrodermal type testing, we have some criteria for focal areas that I've worked with, whether a surgery is necessary or if it can respond, if it's mild to homeopathic. As you test nosodes, that gives you an idea of what kind of pathology likely is there. With tonsils, you can have several things: tonsillar hypertrophy, tonsillitis, tonsillar abscess, and if we find abscess, we get that hint that we have there. If we have just the chronic tonsillitis, if you test the nosodes and you can go to a 3x, that tells you it's a strong focus. If it's a low potency, as you add multiple ampules, and that can be done virtually with the software, with the test sets. as you go above 3 ampules taken to balance the point of that nosode, you'll know that it likely is going to require surgery, and it's not going to respond. And you can always do a test if you're giving homeopathic and injection therapy, is treat it and then go check 6-8 weeks later and see, has it improved at all, has it stayed the same, or has it gotten worse? And if it doesn't get better, or especially if it gets worse, that's immediate indication that it's not going to respond. Surgery is needed. But those are some ways to get some idea. There's cases where we've had tonsil issues in the past. I've treated successfully with homeopathics to the point where it's not acting as a focus. In the real long term, it still is something that could be a problem. And I think we are overlooking the tonsil surgery in lots of cases where it is a latent problem.
Okay, I think you were next, yeah.
I have 2 areas, and it's really about how we could get some more information for the next seminar. The area of restoration, to me, is a huge one. And I was here 2 years ago, and we had the fellow from Scandinavia who showed us the Insuran long span bridges, and they look very exciting. But then when I see the Clifford reactivities test come back, 100% of the people are not suitable for the core of that Insuran. And so, since you can't even entertain taking a tooth out until you've thought about the whole restoration picture, and the materials are so controversial these days, I would love to see the Academy spend more time on the restoration side. And my second area of
Well, why don't you hold on, I have Ed respond to this one, and then we'll go back to you.
What I would do, what you say is right about the porcelain bridge, the Insuran. They're making them by the hundreds and thousands in Europe, these Insuran bridges where they cantilever one tooth out over the phonic area. My recommendation is to you is to shorten it up, get all of the artificial stuff out of the mouth. All the metallic fillings that dissociate, get them out of there. In its place, put bonded composites to occupy the same space that was there with the other metallic fillings, like a gold inlay and or even an amalgam. You get rid of that, and it quits dissociating in the mouth anyway.
I mean, I think the point is well taken. You would like to see more on how to do a proper restoration, what materials to use. Yeah, and towards the Insuram, a personal comment, I had Insuram in the mouth. It is one of the lousiest materials ever, and I've seen lots of Dr. Lechner's complications who goes touting around in Europe the Insuram, because he's one of the dentists who does beautiful work, but he doesn't follow up on his patients. So the long-term outcome is the same problem like here, is handled by the physicians that then kind of handle the disasters that happen down the road. So don't use Insuram, it's a lousy material. We have much better materials here available, the sculpture fiber core and the other newer materials, which are really as good as it's ever been. So, but I would put that, Carol has taken notice, Ed has taken notice, there's more wanted on this.
One of the things you can do when you're using bonded composites is you can bond a small part of that fabrication to the adjacent tooth. You don't always have to make a bridge. Don't make any more bridges, and whatever you do, don't cut any teeth. And then you won't get into any trouble. They may look at you kind of funny. I had a patient come in, and I was redoing all her amalgam fillings, and her friend came with her to drive her down here, and he comes to me and he says, "I like the same thing done to my mouth." And I says, "I didn't know that." So I said, "Okay." So he sat him in the chair, and we took a medical and dental history and checked him out, and we did a serum compatibility test to do the composites that we planned on making for him. So it was the same one we used, Conquest, I think. And we did the whole mouth, and we did probably about 8 units of restorative work, maybe 2 or 3 of which were crowns. The others were onlays or inlays. what we did was, we did this for the person, and about 4 minutes later he comes into the office and he says, "My cancer's gone." And I go, "Wait a minute, I didn't even know you had a cancer. You never mentioned it to me." And we've been talking back and forth for maybe 6 months, something like that. So unless you talk to them, they're not going to tell you everything. And this was prostate cancer. And he was so happy that it was gone. I told him there was just things I didn't like about the restrictions that I had made him. And then I eventually wanted to change him over and couldn't do that because I had a stroke right about that time. And I ended up where I am right now. Just walking around with a metal cane. Yeah.
Okay, you had a second question. Yeah.
And that's that I know that there are dentists really wholly biologically dealing with the cavitations and not using antibiotics and really dealing with the biological implication of these organisms, and this is an Academy of Biological Dentistry, so I would hope that the next time around we'll have some of that kind of therapy represented as well, because as much as I appreciate what you have to do with the amount of antibiotic that you're recommending, and I know that you're seeing very complex chronically compromised people who failed in many other treatments, I also know there are people who are wholly using biological European remedies in the main, and I'd like to see that represented here so that we get a full spectrum.
I'd like to interject that I did give a recipe for a biological approach during my lecture, yeah, which is a very potent approach. If you do follow it, it's really like okay, yeah. Let's try to keep the answers so very brief from here on. Sorry.
I'd like to answer that for you because it's a very relevant question. I've been listening to this, and many of us, like Ed and they're starting the first wave, and we did do the biological approach, but the amount of knowledge and experience that it takes, and the prices to pay to go that route are so difficult. What I think we're trying to say right here is, yes, you're absolutely right. German doctors came in there and told us, no antibiotics, no this, no this, no this. The problem is that in this country, of the state of how medicine and healthcare is practiced and whatnot, the prices that I went through a major lawsuit in the state of California to defend that position. I did defend it and successfully won. But the prices that each of us has had to pay, Ed paid in his part almost in his life. I have paid financially. I'm semi-retired. I mean, this is, even each win like Terry Lee did was significant. But to go to that level that you're asking for, to evolve to that point, is maybe beyond where a group like this can actually do it. There are people doing it in Europe. There are people doing it here, but they're not going to be talking about it. That's the problem that's so difficult here is that what Chris is trying to say is that he's trying to keep everyone out of trouble and try to keep it within the standards of care, within the medical, dental, healing community. And yes, it may not be perfect. I have done surgeries without antibiotics for 12, 15 years. I've had patients come. But the difficulty is that all it takes is one patient. This is what Chris is trying to say, that he's trying to, the amount of layering of information to get to that level. And I think, I'm not a great student, but I think I've studied hard to get to that. And Ed, I know, has studied hard. There's others here who we've all studied hard here. But to get to that level that you asked me is going to require almost another paradigm in our healthcare delivery system, another structure, another system, which is maybe evolving and will evolve maybe in the next 5 to 10 years. And maybe this next generation of healing practitioners here will take it to that next level. I know I'm trying to get it to that next level, which may require a tremendous amount of funds to back the organizations that do this work, because Ed, Carol, Norman, and everyone's here has worked on a shoestring budget. You understand that there's no money in it? Really? I mean, practicing medicine today is not, the golden years of dentistry is over. I mean, with healthcare, socialized medicine. So what you're asking for is a very valid question. To present it to this group, it's a very difficult situation, because how many years can we take to train the so-called next generation of health practitioners? We do need to set up schools, websites, their education. I know this is going to be the next idea of what we're doing, train, and and you as a consumer are going to have to demand it.
Well, that's why I'm bringing this up.
I
I'm
understand
basically
that.
saying I
Well,
would like you to include
Thanks,
some of
Mon.
the
I
people
think your
who
point
are
was very
doing
well
this
taken.
still.
We are an Academy of Biological Dentistry, and that was sort of underrepresented here. That's sort of what you're saying, and I would agree with you. And thanks, Mon, for your comment. There's one other thing, maybe like just this one sentence. Like, we are always trying to get physician-dentist teams together, and we need, like, one appeal to all of you. You need to get away from that John Wayne mentality of the Americans. One man has to do it all. We have to try, that's the approach of the Academy of Neurotherapy. We have to create teams of naturopath, physician, dentist, chiropractor that work together. And the biological part of the antibiotic care is so involved, like Vaughn said. It requires somebody who is wholly dedicated to that part. It needs to be somebody who does muscle testing or EAB. Otherwise, there's no way of guiding somebody through this. Next question was from the speaker next to me.
I have one. I was a little surprised. Several people asked me about getting biopsies, and I thought everybody knew that Jerry's running biopsies for dentists in 38 states now, and I thought we better ask him have him give his 800 number and let you all know that we better be sending for the kits and so on. And along with that, Jerry reported to me on the phone a very interesting case of an endodontist who was sued because of a apicoectomy he did, and he was sued for, I think it was $1,300,000 and lost the case. Why don't you tell him that story, Jerry?
Well, it's not much of a story. It happened a while back, and endodontists were not sending their tissue to any pathologist until this case came up. I think it was 15, maybe 20 years ago by now. And the situation changed overnight to the point where some biopsy services in oral pathology made up half of their tissue comes from apical tissue. So it's a rather dramatic change. And oral pathology is a fairly small community, and I know pretty much all the oral pathologists in this country. So if you don't want to use me, I'd be happy to hook you in with somebody else close by. As far as my 800 number goes, it's 800-632-2656. And we're like every other oral path service. We mail out kits to you that have all the paperwork and the formaldehyde and the return postage. It's really no expense to you. That's not unique to me. That's what we all do.
It can save you a lifetime.
What's that website?
The website is Maxillofacial Center. If you can spell maxillofacial, I figured I didn't want anybody looking at it who couldn't do that. And actually, my 800 number is MFC, Maxillofacial Center, MFC Boko, B-O-K-O. That's how I remember it when I call home.
I think Hale had the next question.
Just some observations. I didn't mean to be over anxious. There was a spirit of Fisher and Rosenau that were pushing me there. And I don't normally talk to spirits, but I'm trying to communicate what it is from this study because, and I'm very appreciative of Dr. Arana having introduced me to Fisher's book, Death in Dentistry. And there's great support there for many of the things that Dr. Boucault was talking about today. So there is not a real void in the literature, but it's not really, people aren't paying attention to it, but an excellent summary of the work that had been done on jawbone infections comprises a good part of Fisher's book, Death in Dentistry, 1940. It's in most medical libraries, and Dr. Arana's office is going to be making some copies available for those who can't get it elsewhere. And Fisher talks about the streptococcus as being the cause, a capillary insult as being next, and then how this causes edema in the various tissues and how all of these various diseases are edemas. In fact, Fisher, one of his earlier books was, he was a physiologist, he wrote Edema and Nephritis textbook, and he wrote the edema section in it's Morris Pearsall Cyclopedia of Medicine, 1939, where he went on and on about how all of these conditions are edemas. They're caused by, and it's extra hydration, and so therefore that's why he was talking about alkaloids to dehydrate things. But mostly he said the cause itself is the jawbone infections, the teeth, the tonsils, and the jawbone, so to get into those. And just a couple things things for Dr. Foucault, just we can maybe pick this up at some point. Fisher referred to tooth infection. Tooth is basically being bone, and so that he said any kind of a cavity, any type of caries is actually osteonecrosis, and so he was not hopeful for any type of restoration that we had as of that time. And just once you choke off the air, that this becomes osteonecrosis, and then it spreads to the jaw. So that's something for consideration. And also then the question is to use Rosenau's methodology. Now that is posted at, some of the best examples are posted, at least that I could find, at instituteofscience.com/vaccines.html. And I'd be pleased to work with anybody on trying to get these vaccines, both culture Rosenau's bacteria, both as a diagnostic tool and as a therapeutic tool. So I think that's real important. And I'll be real brief. The Rosenau, I really do believe he fulfilled Koch's postulates with localization of bacteria in many different diseases. I go along with Dr. Kuno to the point of saying the best medicine is the right medicine, but if we can find the cause of a disease, then we also have its cure. There's 4 levels here. We have the cause, we have diagnostic, we've been talking about a number of things, diagnostic tools, therapeutical tools, and the cure. The cure has to be related to the cause. Now, the diagnosis or the therapy may not be directly related to the cause. It may be very important until we get people to get rid of their oral foci. We need these other things. We need to balance the system. We need to do whatever types of therapies, heat therapy, whatever type of therapy works. These therapies are all being used because they work. So I don't think we can ever start to say any of these therapies are bad, but that we have to recognize that for the most part, unless we have an established causal relationship, that they are dealing with the symptoms. So we must get back to the basic cause, and I believe that this has been proved by thousands of animal experiments to be the bacterial in nature. And I'll just leave you with this just final thought. That being the case, as Newton has said back several hundred years ago, more is in vain when less will serve. So if we have a cause, if we fulfill Koch's postulates and gone beyond, now we know what the cause is. Okay, so we use the therapies we have developed, make better therapies, but we get to that cause and clean out these jawbone infections, these tooth infections, and these residual tonsillar infections. Thanks.
This is addressed to the panel in general, and what I'm interested in is prevention. What should we tell our patients and our children to do? What should they brush their teeth with, and what toothbrushes? I'd like a comment about ultrasound versus ionic toothbrush versus mechanical brushing versus the electric toothbrushes, and with what?
Okay,
and
can
how?
we keep the answers very short to this? Like, just maybe everybody gives a few keywords. I recommend reading the book from Pottinger, his cat experiments, that goes into how the processed foods are really the underlying cause of the whole cavitation issue. And secondly, like one of the things that lately has come up is brushing your teeth with grapefruit seed extract, putting a few drops on a toothbrush. In addition to the non-fluoridated toothpaste, greatly reduce the number of germs in the mouth, and it doesn't sensitize the teeth. It's the only thing we found, the only disinfectant in the mouth that doesn't sensitize the teeth. It's in every health food store.
How about tea tree oil?
Citrucidal makes a
Citrucidal.
toothpaste now with that grapefruit.
They make toothpaste with it in it. Okay.
Nutribiotics in here in California.
Something to be said about calcium carbonate in toothpaste. It can remineralize small lesions, I think. So I would consider using that. No fluoride.
What about the tea tree formulas of the toothpaste that I've seen amazing results with my patients?
I think it's best to mix them up. Don't stay with one thing, because if I don't get used to it, both get used to it, just like antibiotics.
Yeah,
So
tea
just
tree
mix 'em
oil
up.
has a long-term detrimental effect that's extracted with solvents from the plants, and there's solvent residues in there that at the long time may catch up with the health
But
of
that's
the patient.
changing now in the extraction process, just like with grapeseed extract, they use solvents of chloroform and
Yeah, the
methanol.
nutribiotic is clean.
Now
Yeah.
they're cleaning that up or running it through filtration to get rid of those residues.
Next question.
Any other tips here from the group here, Jerry? Any creative ideas? Sort of things, things you can.
tissue all the time.
What about
Retire
the
early.
different toothbrushes? The possibility of reaching out for amalgam fillings, people that use electric toothbrush or ultrasound or.
Any type of electric field applied to the jaw will mobilize metal ions. So that's why we wanting to have people with metal-free mouths, and then the ultrasonic toothbrushes are very good. They don't get rid of plaque as well as regular brushing. So if you have plaque, the ultrasonic toothbrushes aren't ideal, but they're ideal for the health of the gums and jaw.
Any more medical questions or dumb questions for the board?
Yeah.
Want to get answer?
My daughter has enlarged tonsils, and she's 9 years old. And just hearing this about the tonsils, we found a growth on the back of her kneecap, a fatty deposit, and we know from our past history in our family, diabetes, that the pancreas is not working well in myself. And with these tonsils, they were so big that they closed down her mouth, but through different types of treating, we did shrink them down, but there is something in there, I know, but because of that, now I can relate to that fatty deposit, that growth. And it stopped her knee from opening up. She could not expand her leg by herself. She had to use her hand to pick it up. She went and got x-rayed and had an MRI, and they saw this growth there. And until now, they wanted to go in and cut it out. We were able to dissolve it by using an infrared mineral spectrum lamp at DMSO, but the cause we did not treat until today. It's those tonsils.
Tonsils are related to the knee.
Related to the knee, the back of the kneecap, and it was to the point, 9 years old, that it was starting to immobilize the joint. But
once the tonsils have been so dysfunctional, they've been beyond normal, expanded to a certain volume, usually they never get healthy enough to be healthy tonsils in the definition of ISLs.
So it should be removed.
And in this case, if there's already peripheral problems that are experientially at least linked to this, I pledge in this case for removal. We're usually not for early removal. We want children to struggle with the immune system for as long as they can with the tonsils and remove the tonsils later. Tonsillectomy, in my book, is something that should be done like wisdom teeth, when you're in your 20s. That's the ideal time to do it. Then the immune system had that struggle for long enough to get the strength from it, and then the tonsils usually are used up.
On that same note, from a traditional Chinese perspective, there's a divergent meridian that moves out of the bladder meridian through the tonsils. So if you watch the bladder meridian and its pathway, there are strong associations with the tonsils, and of course the back of the knee is an area where the bladder meridian.
Thanks. I didn't know that.
This is for Jerry. I was really interested, Jerry, in your description of bone marrow edema and what you characterize as transient ischemic osteoporosis. It really seems to fit into the category of circulatory diseases, particularly microcirculatory, in a localized area. And it certainly brings me back to the point of saying, quite apart from the impediments in our coagulatory factors and so forth, just how good is our aerobic capacity. And I have a feeling that most people's aerobic capacity, even nowadays we see them with kids, after the age of 16, with the tremendous increase in obesity in North America, is very rapidly diminishing. And I think that this might be a profitable avenue for us to think about, not just with aerobic and oxidative therapies, but thinking about how we can enhance the whole circulatory function of people. It seems to be just a spin-off of this.
Yeah, I think you're right. This is a circulation problem, and the bones just the marrow spaces happen to be a very unusual, susceptible place for people who have a generalized ischemia, I guess you could call it body-wide ischemia. I should mention, I didn't during my talk, but the term bone marrow edema was first put in a dental journal by myself about 6 months ago, but it just came out this month in OOO, the main oral path journal, and it was a radiology study. People looked at the joint looking for arthritis, and they found that half of their cases didn't have joint arthritis. They had what in their terminology was called osteonecrosis and bone marrow edema. So it's, and I had nothing to do with that paper.
You were saying that it's transient, but that means that you have blood flow come and go.
It's transient in the hip.
We don't know.
We don't know. A lot of the we can relate a lot of the hip and knee literature to the jaw because we know microscopically it's the same disease, and we can make assumptions that it is otherwise the same, but we haven't really proven that the physiology is the same.
So if it is transient, perhaps we can improve the blood supply of the area rather than do surgery.
Let's try to
Yeah.
kind of keep the format of like so one question, one answer, so because otherwise you'll be really deprived of the people who are asking the question. It's not the time to have a dialogue.
It is, I wouldn't mind seeing people try to enhance vascular flow. However, if you do enhance vascular flow and you have a patient who has an outflow problem, are you now pushing more blood into that area and thereby increasing the pressure in that bone marrow? You know, there was a question, how common is this? I guess in the days when we were thinking that osteonecrosis is an inflow problem, which goes back 15 to 20 years, there was one study of the jaw that looked at inflow into the jaw bones, and this was a Finnish study of mandibles only, and they found 11% of cadaver cases with what they called significant or total blockage of the inferior alveolar artery. Total blockage in patients, there's no commentary in this thesis about whether there was pain or not. But that's a significant inflow problem. It has nothing to do with the outflow.
Just arteriosclerosis they talk about now?
Mostly arteriosclerosis, or as the patient aged, muscle tone got worse, and so the inflow of the artery was like an accordion. And Bob McMahon and I have 11 patients now where we have looked at the inferior alveolar artery, and it's nothing but fibrous scar tissue. There is no blood flow through that vessel.
One thing I'd like to mention, you mentioned the bite being somehow related. One of the studies, or one of the results that we did on a patient, this is in an educational setting, where we had different professions working on patients. This particular person through EAB testing came up with multiple cavitations. And in looking at the x-rays, panoramic, one of the things we decided to do was to put some paper, wad paper up, and have a bite on it. And actually, in adding vertical dimension to the jaw, those cavitations no longer were like the primary focus, it was actually the jaw, which went along with her problem of anger. And we had her, we had her go to like Al-Anon type thing, but it was actually the anger issue that caused clenching. She totally wiped out the occlusal height on her partials. I mean, everything was like out of balance. So it would be good to have people maybe check when there are cavitations, look more at bite relationships, or maybe test if you have EAB or muscle testing to use to see if that is an issue, and then maybe more at the emotional issues that might be correlated with that also.
I think that's a good point.
In addition, whenever you have the bite problems from grinding, it's oftentimes related to parasites. So if you'll look for, get rid of parasites, the grinding improves too.
One of the things that I would like, I don't know, this is something I've been thinking of for years, but the teeth are piezoelectric, bones piezoelectric. As you bend it and torque it, it sends out a charge. One of the things that we know with blood clotting, things begin to clot when you go from a positive to a negative in your vessel. And so with that negative energy, you're going to be creating a different kind of situation. And that's what I thought about with the cavitations too. Is it possible with pressure or with the changes in that electrical current, are we then creating ischemia because of that change in charge? And if you're cutting off your blood flow back there because of structure, again, head forward position or tension, stress.
I think that's a good point. And we should always keep in mind, osteonecrosis is not a disease in the usual sense. It's a result of a lot of different things that can cause impairment of the blood flow through the marrow space. That's why it's been so difficult to get a handle on it. Even the coagulation stuff only accounts for one level of the disease process.
Tommy, the next question.
Is cavitation a disease of civilization and dentistry? If we can tell from an autopsy specimen whether the disease was present. Can we tell from a desiccated bone, from the skull alone? And if so, has anyone looked at collections of skull from different periods and locations and to see what the incidence is?
No, but there is one case report of a osteonecrosis in the jaw of an Egyptian mummy that was preserved, mummified, 2,800 years old or something. But I don't know I don't recall how they diagnosed that. There was just this cavitation within the jaw. That's the only case I know of.
There was some reference to some of the literature, some stone men. They found jawbone, evidence of jawbone operations, no caries, but impacted abscessed jawbones. And the thought was that this had come from the type of foods that were eating these hard nuts, and you crack the stones, and that was ending up causing the jawbone. And that's, that was speculative. But there is evidence of that in historical literature of stone from the Stone Age.
Can we hear a word about metabolic typing and how to pursue education in that field?
Thank you for asking. Okay, there's a website to contact, and that is healthexcel.com. It's HealthExcel.com, and that's Bill Walcott's website. Dr. Crystal also has a website, and that is bloodph.com. Bloodph.com. We are planning to do, in terms of who I am also a metabolic advisor. I've been working with the Health Excel program, which is Bill Walcott's company, for the past 3 or 4 years. We are anticipating having another seminar. We just finished one, and probably the May or June timeframe. So we're going to be doing a mailing. I've received business cards from a lot of people requesting interest. Please make sure I have your business card when you leave, or your address or something, so that I can make sure to include you in our mailing of just educational materials on metabolic typing. Some of the questions somebody was asking last night about Pottinger's work, about the autonomic nervous system counterpart, and that work is based on the work of Francis Pottinger. He wrote a book called Symptoms of Visceral Disease, which you would find very interesting, and his work was based on, in 1910, Eppinger and Hess noticed in their research that some people, even when healthy, had a predominance towards either a parasympathetic or a sympathetic functioning. Pottinger went on to do his work, and he noticed that when he introduced potassium, it was the same thing as stimulating the parasympathetic system, which was the same result he got when he added hydroxide ions, made it a more alkaline situation. And likewise, when he added calcium, it acidified the system. It also had a sympatheticizing effect on the autonomic nervous system. And hopefully that'll answer a little question someone had about the autonomic system counterpart.
Who's next? Question to Jerry. Do you think osteonecrosis, is it a histological diagnosis or is it a radiological diagnosis?
It's definitely a histologic diagnosis in the jaws, but especially the more mild cases like bone marrow edema syndrome in the long bones is almost always a radiology, an MRI, and Tech 99 diagnosis. They don't go into to confirm the biopsy. Yeah, I think it must be the irregularity of the jaws. It does not allow us a good MRI interpretation. But these guys with the TMJ study that just came out might help us.
Are SPECT scans for blood circulation of any value for these problems, like we use for the brain?
SPECT scans are, they're quite useful, but you still have to use the same basic radioisotope that attaches to calcium or hydroxyapatite. It really doesn't do any good to try to attach it to another cell.
Yeah, they can do a two-phase scan, though. They do an early scan and then a late scan. The early scan looks at blood flow, the late scan looks more at tissue effect.
Right. I think all the scans come in two-phase.
Jerry, you said that the osteonecrosis you find in the jawbone is the same type as you find in the other bones.
We're assuming it's the same, yeah, because it looks the same.
From your standpoint, how about teeth? Have you looked into the teeth in terms of the decay or what you Nancy Fisher said the tooth is a bone, and that is osteoporosis. Do you have any observations?
The question is, how does a tooth relate? And I guess it would be the pulp, because I'm mostly talking about bone marrow, and the pulp would be the equivalent in the tooth. And there is a little bit of correlation. This sort of fibrosed, atrophic fibrosis that occurs in bone marrow does occur in tooth pulps. That's what I refer to as a mummified pulp. But I find it fascinating that the calcium salts that we get in these dystrophic calcification cases or chronic calcific pulpitis cases, they look very similar to some of the calcium salts that get deposited in the dead fatty tissue. And since there is no fat in pulp tissue, it's kind of hard to equate the underlying